Okay, good afternoon, folks. This is Dr. Brian Crable from the University of Scranton. Um, Today, in Volume 4, or the fourth video, Video 4 of my Epidemiology during COVID-19 series, I wanted to talk about some of the social and cultural aspects that we see related to epidemiology. And so we'll talk a little bit about burial practices in West Africa during the West Africa Ebola outbreak. We'll talk about vaccine compliance here in the United States around sexually transmitted infections like HPV. And then we'll talk more broadly about some of the social and cultural trends that we see influencing not only our ability to treat diseases once they have established in a population, but also our ability just to know what's out there and to be able to track and surveil diseases and infections as they make their way through the population. So again, just to orient you as far as where we are in the video series, so the first video was sort of an introduction to this series. Video 2 focused on chains of infection. Video 3, we looked at patterns of infection and things like the difference between an epidemic and a pandemic, and the different types of epidemics that we can have: point source, common source, and a host-to-host or a propagated epidemic. This video will focus on social and cultural aspects of epidemiology, and then the fifth video will take a deeper dive into COVID-19. As many of you may recall, in 2014, there was a widespread outbreak of Ebola in a number of countries in West Africa. Of note, this particular epidemic resulted in actual transmissions of Ebola outside of Africa for the first time in history. This really was a devastating disease. So, folks probably now are aware of the issues surrounding Ebola, how infectious it is, and what the prognosis is. And basically, it's highly infectious, especially when you make contact with bodily fluids. And because of the nature of the infection, there are a lot of bodily fluids. So the infection, the disease really is devastating. There's a very, very high mortality rate, a mortality rate that exceeds 90% of folks diagnosed with Ebola, especially in developing and underdeveloped regions. There's a really high fatality rate associated with Ebola. One of the ways that it spreads, and we learned as the World Health Organization and Doctors Without Borders were going in. One of the ways that it spreads through a community is through contact with bodily fluids, and typically in hospital type setting, you minimize contact with bodily fluids. But in a number of these villages, the community they would wash their dead before burial. There was a lot of contact between the community and people who had recently passed from Ebola. And as you can imagine, this led to a lot of transmission. There were a couple other cultural factors at play. So one thing was a distrust of Doctors Without Borders. So as these aid workers were entering villages trying to get a handle on the prevalence and the severity of the infections, folks would hide sick people because I mean, understandably, right? So these people wearing these hazmat suits show up out of nowhere and suddenly start asking if people are sick, and so you hide people who are ill, and of course the aid workers are also trying to prevent you from carrying out your cultural customs of washing your dead before burial. And so it's a really, you can imagine, a very concerning and very intimidating situation for these communities to be in. And so this was sort of, I think, a highlight of how cultural and social values and customs interact with epidemiology. But I want to highlight, and we'll talk more about this on the next few slides, but these social and cultural influences on epidemiology aren't just limited to West Africa. They aren't just limited to developing nations. In fact, in the United States and in Europe, there are a lot of social and cultural aspects that influence our ability to track and treat diseases in fairly negative ways. And we'll talk about that as we go on to the next slides. So what I'm showing here is a political cartoon that was circulating during some election in Texas. And I mean, you can read the cartoon itself. The candidate We finally found a legal way to exploit the bodies of teenage girls. And then, of course, there's this representative from Merck saying, nice doing business with you, Governor. And then there are a bunch of what appear to be 12 and 13-year-old girls getting in line for an HPV vaccine. And the sign says, get your sex vaccine here. And then the house, title on it was the best little whorehouse in Texas. And that has been crossed out and changed to say the best little vaccine house in Texas. I think what this highlights sort of is the some of the challenges that we've had with respect to the HPV vaccine, and I think it really is a classic case of how social and cultural values negatively affect our relationship with disease and infection throughout the United States. And I think it's certainly something that we want to do a little bit deeper of a dive into, so that we can then understand some of the social and cultural issues that impact other diseases and may be impacting our response to COVID-19. So, of course, as you may imagine, there are some sensitivities around sexually transmitted infections, and especially when we're talking about sexually transmitted infections among young children. And one of the common refrains is that, well, I don't need to get my son or daughter vaccinated because he or she isn't sexually active. And there are a couple issues here. One is that, no, your 12-year-old, as the data shows, this graph is from the Guttmacher Institute, your 12-year-old probably is not sexually active. However, by the time that child is 16, a fourth of females and close to a third of males will have been sexually active at some point. And many of them are not comfortable discussing their sex lives with their parents. And really, the best time to get a vaccination the best time to get a vaccination for HPV is before someone becomes sexually active, right? So we all get the flu shot in October, even though the flu isn't necessarily circulating, because the best time to get the flu shot is before someone with the flu sneezes on you or coughs on you. Similarly, with HPV, the best time to get the HPV vaccine is before you become sexually active. And we know, by the time children or our students, adolescents are, around 18 or 19 years old, at least half of them have become sexually active. And so if we haven't taken the opportunity when students are 12 and 13 to vaccinate them, then we're really diminishing our ability to help control the HPV infection. And HPV is particularly challenging because, again, there are no outward signs of infection. It doesn't typically lead to disease until later in life when people develop cervical cancer or, depending on their sexual practices, throat cancer or anal cancer. And there was an opportunity when they were 12 or 13 to really make a difference to vaccinate them and prevent the spread of infection. The other challenging aspect with respect to sexuality among adolescents and our ability to control HPV is that typically, things have gotten better as people have become more sexually literate, but this graph here again is showing the contraceptive use, basically the condom use of students who at their first sexual encounter. So students from 15 to 19 years old, the first time they have sex, whether they used a condom or not. And you see, we certainly see increasing compliance with folks using condoms more frequently at first sexual encounter. But one thing I want to highlight, so the condom is the only effective method for preventing the spread of HPV during sexual contact. And even today, right, so 2006 to 2010, at least around 30 to 35% of students did not use a condom at their first sexual encounter. So this, given the prevalence of HPV in our society, gives, there's a really high likelihood of transmission among adolescents who are becoming sexually active. And so we miss an opportunity when they're 12 or 13 to vaccinate them and just hope that they'll be forward with their parents about when they plan on becoming sexually active and all of this. But at the end of the day, parents don't want to admit that their son or daughter is the 1 in 3 15-year-olds or the the 1 and 2 16-year-olds that's sexually active, they haven't had those conversations with their children, so they don't know. And so it really creates an issue where these infections are circulating among our young people, and we're really challenged with getting a good handle on these infections. The other thing that I'd like to highlight with this is that HPV in particular isn't just a single shot, right? So we need to have 3 shots to have complete compliance. What this graph here is showing is the low compliance rates across the United States, right? And so among 13 to 17-year-olds, only about 30, maybe 45% of females are in compliance with all 3 shots, and only about 30% of males are in compliance. And of course, another challenge is, well, the vaccination is only for girls. Boys don't need the vaccination. And there are a couple challenges here too. One is that boys, when they become infected, they can still transmit to girls during unprotected sex. The other aspect to it is we know that depending on sexual practices, the HPV vaccine, or not the vaccine, but the HPV infection can lead to oral or anal cancer, and so boys certainly have risk factors there. Again, depending on their sexual practices throughout life, and so it really highlights that we're not doing the best that we can. We're not covering our adolescents with the HPV vaccine nearly at the levels that we would expect, given the prevalence of sexual activity among adolescents in the U.S. Okay, so we talked about HPV. So let's move on to how social and cultural aspects have influenced another sexually transmitted infections. And I particularly like talking about sexually transmitted infections, or STIs, when we're talking about cultural and social values, because I think you can really see these shifts, these cultural shifts over time. And I think one of the classic cases for this is gonorrhea. And just to for my students, to introduce them to gonorrhea. So gonorrhea is a gram-negative organism. It's diplococci. It's a strict parasite, so it doesn't survive long outside of the host. And we'll talk more about this in class when we talk about parasitic relationships and symbiotic relationships. Gonorrhea can be aerobic or microaerophilic, meaning that it requires oxygen or very small amounts of oxygen. One thing I do want to highlight, so next to HPV, so next to human papillomavirus, gonorrhea is the second or third most common sexually transmitted infection among young folks. And I just want to take a second to highlight also that about 1 in 3 Americans are living with a sexually transmitted infection. So I think societally they are an interesting type of infection to talk about. Now on the next slide, we're going to take a look at gonorrhea transmission over time, and I think that will make clear how some of these shifting social and cultural values really influence our ability to track diseases and also our ability to control the spread of infections. All right, so this is the graph I was talking about on the last slide. Basically, what we're looking at here are the number of gonorrhea cases per 100,000 population. So again, this would be the morbidity, going back a couple videos, the morbidity of gonorrhea. And what we see here is that prior to World War II, there was a very relatively low level of prevalence of gonorrhea within society. So this graph, the y-axis shows the rate per 100,000 population, and then the x-axis shows the year. So we're looking at years 1941 through about 2017. And this, again, is from the CDC website. We see with World War II, we see an increase in the rate of gonorrhea. GIs are going over, they're away from their wives, they might be visiting prostitutes. We see an increase in the number of gonorrhea cases in the United States, and presumably this is with respect to GIs going overseas, and contracting the infection while they were over there. Following World War II, sort of a return to pre-World War II attitudes and behaviors, we start to see um, gonorrhea decrease. Then we hit the Vietnam War, so we get a little bump there with soldiers again going over to Vietnam, and again potentially visiting prostitutes while they're away from their wives or what have you. And then, of course, we have the sexual revolution, right? So we have the Summer of Love, we have Woodstock, we have, a lot of just opportunities for transmission would probably be the most politically correct way to talk about what's going on during the sexual revolution. And so we see really we've spiked from about 100 morbidity of about 100 patients per 100,000 population, almost 5 times higher by what's that 1973, right? So we start seeing really just a drastic increase in the cases of gonorrhea, and of course following 1980, 1981, we start to um, see some decreases going on right around 1980, 1981. So we start to see gonorrhea dropping away. And I sort of think what's going on there, right, is that's when we start having, the when we start hearing about HIV and AIDS, we start recognizing that that is a particularly challenging sexually transmitted infection. So people start using condoms a lot more frequently. And so because they're trying to prevent acquiring HIV or AIDS, we're having this unintended consequence of lowering the rate of transmission of gonorrhea. And so I think gonorrhea in particular, you can sort of see these shifting social and cultural how these the shifting social and cultural landscape influences our relationship to infections and diseases. And again, I think these are typically very, very obvious when we're talking about sexually transmitted infections. Again, because of the sensitive nature of STIs. Okay, and on this final slide, I just wanted to highlight a few things that it's not just HPV, it's not just gonorrhea. I mean, you can see throughout the recent history how social and cultural values have influenced our ability to track and treat infections. And so I know, from my childhood, HIV and AIDS was constantly in the news. And up through really about the late 80s, it was primarily considered to be a disease that affected men who had sex with other men. And so, because of that, and because of biases that surrounded that particular demographic, there wasn't a whole lot of effort made at treating and developing treatments. At least in my experience, it didn't really become a high-profile disease that people were really trying to tackle until 1991, when Magic Johnson came out and said that he had, in his words, he had attained HIV. He had acquired the human immunodeficiency virus, presumably through heterosexual sexual contact. And so this really, I feel like, was a watershed moment when people realized that HIV/AIDS was a broad-based sexually transmitted infection. It wasn't just confined to homosexual men. That it could could impact heterosexual relationships. And we started to be more and more aware of transmission through things like needles and blood transfusions and other ways that HIV and AIDS could spread through the population. It's also led to increased funding for research, awareness of condom use, and with that awareness of condom use, we started seeing decreases in other sexually transmitted infections, so things like gonorrhea and syphilis. So I also want to highlight it's not just sexually transmitted infections. So there are other things that come into play when we're talking about epidemiology and how we track and treat diseases. And I'm sure you can imagine that epidemiology and tracking and treating infections touch on a lot of domestic policy issues. And that's one reason why I think the conversation around COVID-19 is so loud, is because they do touch on a lot of domestic policy issues. And a couple that I'd like to highlight. So it touches on health insurance trends, right? So folks who don't have insurance tend to delay treatment. When you delay treatment, you infect more people. Folks who don't have sick days tend to go into work when they're sick. They can infect more people. And it's also difficult to surveil folks who don't seek treatment, right? So if you don't go to the doctor, if you don't go to urgent care, and your infection doesn't get reported, then you are still in contact. You haven't self-isolated. You're in contact with other people, so you're continuing to spread that infection. And so a lack of health insurance. So we know that infections typically can spread more broadly with less ability to detect um, in communities that don't have adequate health insurance. And then, of course, a specific community that doesn't have adequate health insurance are unauthorized or undocumented immigrants, right? And so, not only do they have many of the same challenges as folks without insurance, in that they may not be able to take a sick day, they probably are going to delay treatment, they're going to continue to infect more people. But there's also this added complication, right, which is the fear of deportation. So this fear of, well, if I go to urgent care and I'm sick, I'm going to be deported. And that's true regardless of whether or not the an immigrant is documented or not, right? So we have in our recent past, especially with HIV and AIDS, we've deported people who were here with documentation because they contracted this infection while in the United States. And so this really adds an extra layer of complication when we're talking about trying to surveil and mitigate infections population wide.